Well, good morning and welcome to Grand Rounds. So our CME color of the day in honor of our guest will be black and gold. So two colors today, black and gold. But we're really excited, first of all, to see everybody back together, or at least some of us back together, and some of us I know are online, but we got a lot of our hand faculty and some of our residents here, so it's good to see you all back. One of the exciting things that's happened over the past 18 months is a strategic alignment partnership, right, Andy, with Wake Forest. And one of the really cool things about that for us here in Charlotte is it's going to bring a medical school to Charlotte, which, as you all know, we're the largest metropolitan area not to have a four-year medical school. So we will have that. That will be a Wake Forest Medical School. We'll also have an innovation center, and that's pretty exciting for us in musculoskeletal because we got big plans for what our education and innovation opportunities will be in that facility. Was a part of getting to know each other, and some of us have known each other a long time. We're going to do a chair exchange with Wake Forest. And so I'll be going up to Wake in June, and we're really excited to have Dr. Andy Koman with us today. So many of you all know that Dr. Koman's been a national leader in hand and microvascular surgery, also pediatric surgery, and it's been a good friend of mine for about 30 years now. And we share a lot out of the Duke lineage. And so it's been fun to watch the parallel development of the program in Winston-Salem and the program here. And now it's going to be fun to watch how we grow together. So let me tell you a little bit about Dr. Koman. Those of you that have been living under a rock and don't know who he is, he's quite a national leader. And he was born in Winchester, Virginia. Went to Duke for his undergraduate school. Actually was on the faculty at Duke. You may not know that after finishing his training and residency there. He went to Wake Forest in 1981 and has been there ever since. So it's one of these unusual careers where Andy was able to stay in one site. Certainly that hasn't been my story. But Andy's wife, Lee, they have two children. They now have two grandchildren. And I'll tell you one interesting fact about Andy that you probably didn't know is he was a tennis star. Andy played at Gilman. Those of you from Baltimore or that region know all about Gilman School, which is a fantastic school, and they have great sports teams. But Andy played on their tennis team, then played on the Duke tennis team. And this was what I did learn about Andy that I didn't know. He actually was a professional tennis instructor during residency. So some of you all moonlight, like Sims I see out here, you guys were moonlighting or whatever to make a little extra cash. Andy was out on the tennis court, earning coin, teaching people to play tennis. He's got a lot of recreational interests, and I'll show you a couple pictures of that, but he's very noted as a golfer, and I'll show you what I think is his coolest hobby with the model trains. So professionally, Andy has been a professor for a long time, but one thing I didn't know, he's also a professor of pediatrics. He's got, during his tenure at Wake Forest of about 40 years, and this fall in October, he will have trained many hundreds of residents, 40 hand surgeons, established the hand and microvascular fellowship there at Wake Forest. They started an interesting program, he and Andy and Gary Paling, back in 1999, this physician scientist program, which is a postgraduate program that has resulted in 21 graduates, I believe more than half of whom are PhDs. So that's been a great program he's proud of. As you would expect, about 200 publications. He's been a visiting professor 88 times, 30 states and 10 countries. He's got an honorary doctorate from Athens, Greece, and this is from teaching all the Greek surgeons, and that's a club that I'm in as well. Just fantastic group of folks in Greece, and just about all of them who have any academic stature were trained here in North America, a lot of them by Andy and the folks at Duke. As we were talking a lot about Dr. Sabiston at dinner last night, folks who were there were hearing stories of the man, Dr. Dave Sabiston, but as Dr. Sabiston would say, he's a member of all of the appropriate societies. And he's also been president of 7 of them, including the American Society of Surgery of the Hand and also the Southern Orthopedic Association. He's the editor-in-chief of the Journal of Surgical Orthopedic Advances. And one of the exciting things about that, Andy will talk to you about later, is the opportunity we have to develop a journal for our atrium musculoskeletal. So that's one of the things that'll be great about our partnership, and he'll give you some detail on that. As far as academic awards, the list is too long, but I'll go through a couple highlights. He's received the Nix Award for Ethics from the Clinical Orthopedic Society in 2019. He was an honored surgeon in North Carolina from the NCOA in 2013, an honored professor at the OSEP meeting in Las Vegas, which actually it's become one of the biggest meetings of the year outside of the academy now. The Arthur Hune Award from POSNA for research excellence, which was a sort of career achievement award. Clinical Research Award from ORAF twice, back in 1999 for a physiology paper, and then later in 2019 for his work on botulinum toxin. So my wife is asking Andy to come over and do some treatments at home. He's so far refused. So see what happens with that. He's been a U.S. News and World Report Best Doctor, and also Castle Conley. These aren't local or regional awards. These are national awards for 25 years, ever since they started those rating scales. He currently manages 70 clinical faculty, 5 PhDs, and 30 residents at Wake Forest. So I've overlapped a fair amount with Andy and some of his personal interests. As you can see on the screen here, is his favorite interest is his family. He spends a lot of time with Lee. They do some travel pre-COVID, and hopefully, once again, now that we're getting past COVID, it's got beautiful grandchildren and children. He's a big fan of Wake Forest athletics. He's also a big fan of Duke athletics. And then you can see one of his avocations here. This was a trip with Lowry Barnes down in Arkansas that we took when we were both involved in the leadership of the Southern Orthopedics. Andy, I don't think you shot any of those ducks, did you? Shot one. And then he's an avid golfer, and so we'll put that to test this afternoon. Niesel's going to test his skills out at Carmel. What I was really impressed with, and I visited Andy up in White Sulphur Springs. He's got a beautiful place at the Greenbrier, and this is his entire basement. I tried to do a pano as best I could with my phone, but the entire basement is taken up with this model train set, and this is all hand built from scratch. And I don't know how many transformers and switches and different trains you got going all at once, but it was quite impressive. So I just didn't know that. I knew Andy was an engineer, but I didn't know he was this kind of engineer. But you can see a picture of one of his grandsons here on the right, and they obviously get great pleasure out of working on the trains with Andy. So Andy, you're going to talk to us today about penetrating injuries in the upper extremity and microvascular consequences, and really couldn't be more excited about our work together in the service line. And thanks for coming to join us today.
Thank you. Thank you, sir. Well, it really is a pleasure to be here. Most of what he said was true. I actually, during residency, I didn't teach anything. That was in college that I did that. The NCAA probably never investigated it, so I probably didn't have amateur status according to stuff at that time, but that's all right. I didn't play in any matches that mattered anyway. I was sort of like the sub, so it made no difference. And was some other little thing on there, but anyway, it was. Thank you for that very kind introduction. Let's see. Will my talk just come up? Yeah. So what I want to talk to you about today is penetrating arterial injuries. This is something that I've been very interested in for years. I started off, I did a year of pediatrics, and I was always going to do pediatric orthopedics. And then we were doing microsurgery at Duke and replantation. And I said, well, and for the residents here, take advantage of all these things. I mean, I was going to be a pediatric orthopedic surgeon, but I started doing replants and got interested in hands, and I ended up being a hand surgeon and congenital hands. And then along the way, I was playing golf. So golf is actually very important. So one of the major things in my life, playing golf with a friend of mine, a pediatric ophthalmologist in Raleigh, Carolina Country Club. On the third hole, he said, well, you must be using oculinum. That was before it was FDA approved. That became Botox for your kids with cerebral palsy. And on the sixth hole, I said, what are you talking about? And I ended up calling Alan Scott. And 30 years later, I've have spent a good part of my career doing that. And it's just sort of the same. I got started in vascular problems. I had a patient in the ER that had an ulnar artery thrombosis. Looked up the literature. I reviewed Urbanics. So part of what you can do is just, keep your eyes open and look at it, because there are all these things out there that suddenly you can actually become an expert in, and you find out that nobody actually knows much about anything. So I'm going to tell you what I know about penetrating arterial injuries. I put this together about 7 months ago. I thought I'd go back and look at the literature. I thought that'd be easy. So I did PubMed. It was 8,000 articles. I did some more stuff. I got it down to 1,000. And what I'm going to give you is sort of my experience based on this critical review of the literature. I don't have any disclosures. I do want to show T just a little bit. Oh, I know. The other thing is I don't shoot a lot of ducks. I shot 1.5. So I know I shot and one fell. 2 people shot, 1 fell. I took half credit. So that's it. But when people come to my house, the thing they look at the most is that picture where I did nothing. But so here's T, and you can see him around the world. But the most important one is this one closest to me. That's a little. This is at a hand meeting. This is at the Duquesne. So he's actually really deep down. He's a hand surgeon. So let me talk a little bit about this. Obviously, this is a significant arterial injury. This is a 24-year-old motor vehicle crash, 5.5 hours of warm ischemia, shock. We resuscitated her, and the nerves weren't avulsed. And so we put this arm back on. We explored it. We did a shunt while we did the debridement. We first shunted the artery, and then we let it bleed out. We sort of bumbled into that because fortunately a few years before in Louisville, they had hooked up the arteries and veins, and then basically the patient died because of all of the metabolites that were left in the arm. So we did that. And so we sort of bumbled through this, and it worked out. We shortened the humerus, we fixed all the vessels. Big problem we had was getting the bone to heal, but finally the bone did heal. And then it was pretty good. And it was a lot better than a prosthesis. She had elbow motion. She got some wrist motor. She got protective sensibility, never got measurable 2-point, had no pain, did have cold sensitivity. And it was a lot better than a prosthesis. So, we thought this was pretty smart, but I'm going to go back and show you what they did in the 1700s and 1800s and show you that really people have known this for a long time. So what I'm going to do is really a quick annotated review of the literature and put this in the perspective of my experience with replantation and revascularization, but sort of look at some of the issues of what the environment does. We think we're in charge, but the stuff that has happened to the patients is a lot more important than some of the things we do, and we need to modify those. And then look at the impact of the anatomic and physiologic issues after the injury, and then give you hopefully some guides to the indications for arterial reconstruction. If you look back historically, Hallowell sort of described, he attempted an arterial repair in the 1700s. He put a metal tube and then put some catgut suture around it. Didn't work. And so nobody did it for a while. And then Postomdesk in 1886 did a lateral arteriotomy, and that was actually just a longitudinal rent, and he sewed it up and it stayed. There were reported in the literature, over 100 cases, including 40 repairs of end-to-end anastomoses, and then it just went out of favor. Okay, and nothing really happened for a while. But in the early 1900s, Alexis Carrel described the repair techniques. In 1912, he won a Nobel Prize for it. But in spite of all of that, until the end of the World War II and the Korean War, what everybody did was just ligate the vessels. And I'll show you some of the data on why that was a mistake. Boswick, interesting, I'll show you that article. It did a bunch of repairs, all of which thrombosed. And then sort of a classic paper that we looked at in 1985 about why non-critical injuries, what happened to them. So what happened? Well, we had in 1912, all of the things that we needed other than antibiotics and blood resuscitation, but we had all of these techniques were available, and it was just ignored. The data was incorrectly interpreted. It wasn't acknowledged that it was done, even though Alexis Carrel got a Nobel Prize, and it just went on and on. Now, along the way, we got advances in resuscitation, transfusion, to Breedmont in World War II, and still until the very end of World War II, they said just ligate the vessels. We had new sutures, we understood fracture management, we had internal fixation. And it was really a shame because this was just a confirmation bias. People that had decided, the professors said, well, you should just ligate it. And so everybody said, all right, we'll just ligate it, and just plain hubris to not do it. So if we look at what happened in the amputation rate in World War II, the amputation rate with ligation, and these are for major vessels, was 24%. And at the end of World War II, and I'll show you this paper, which is fascinating, they shifted and it dropped to 3%. So the last 6 months of World War II, they started, the surgeons got fed up and they said, we're going to fix the vessels, and the amputation rate dropped. During Korea, then it got ignored. And so in the beginning of the Korean conflict, they kept ligating it. The surgeons there again got disgusted. They started repairing them, and it dropped from 30 to 6.7. During Vietnam and the upper extremity, it was 5%. Iraq and Afghanistan, it went back up, but that's because of the mechanism of injury, and the IEDs and things changed what happened. It wasn't, obviously we were better at that point, but we had not as good results. This is the classic article by DeBakey and Simeon in the Annals of Surgery that set the stage for what we shouldn't have done, okay? Greater than 60% of all the upper extremity amputations were related to arterial trauma. And that they reported was 3 of 81 successful repairs in 2,471 injuries. And so from that, they recommended ligation. But if you go back and look at it, 24% of the upper extremity amputations were secondary to arterial injury. This review was only of 4 hospitals. There were, over 30 hospitals that should have been reviewed. And in that data, the amputation rate was 50% after ligation and 35% after repair. So there weren't very many repairs, and they weren't very good at it. Barr was a resident working with Ken Cherry and Norman, and he decided that he would just go back. He became a fellow. I think he did this during his fellowship, and he reanalyzed all of the data in all of the hospitals. Apparently, this was an unbelievable undertaking. And in the last 6 months of the war, he looked at when they started doing repairs again, and concluded that the data was correct, but the interpretation was wrong, and the data was incomplete, and that repair was preferable, and there was a significant and dramatically lower amputation rate with repair. So a classic article refuting a classic article. Now, this is fascinating. Hughes did two papers looking at the Korean experience. Now, look at that. Remember, I went to, in the 1980s, 90s, I showed you that replanting, all those things we did, but we were so smart. But look what he said in the 50s, okay? The key was priority. You need to evacuate them, resuscitate them. You needed to use general and regional. This is interesting. This is a vascular surgeon. The vascular surgeons still say not to use tourniquets. He said you need to use tourniquets. They used 5-0 silk because they didn't have much else. So obviously we can do better without that. The key was resecting the damaged vessels. Right, Glenn? This is what we teach everybody. I mean, this was there, we thought of something. Key was mobilizing it, when to use grafts. The key was to cover the vessels with muscle or fat, to do fasciotomies, leave the wounds open. Actually, during World War II, it was a court-martialable offense to close an open wound. You had to come back and do it secondarily. And how horrible fractures were and the importance of those. He also said back bleeding wasn't reliable. You actually needed to confirm that there was pressure. And then post-op, secondary wound closure, window the casts, monitor them, and then they use some sympathetic blocks. This is some of his data if you look at it. So these are the vessels that really they were looking at, the subclavian, axillary, and brachial. The forearm, they sort of glossed over. Most of those were single vessels or critical, but they did talk about that if both were damaged, that you ought to repair them both. And so you can see what's going on. And here's the key data. So with ligation on the left, you had a 20 and 33% amputation rate. And with repair, it was a 6.7 amputation rate. So no question that this was the thing to do. And they did talk about, they talked about the radial and ulnar arteries, which of course to us are the major arteries, but that you can safely ligate one of the 2 principal ones. where both you should attempt to repair at least one, if not both of them. This was an article, was never published, but it was in the proceedings of the American Society for Surgery of the Hand. And Boswick did this. He repaired 65 single vessels in the forearm, did them all himself. He arteriogrammed them, and 100% of them had thrombosed. Now, this is in the 60s. And he's supposedly using micro technique, as we were just getting started with that. So very brave paper, but a little bit foreboding. Richard Gelberman, he decided that we would look at this. So we did this multi-center study. The fellows hated this study because Richard said that the attendings had to repair all the vessels, so we couldn't blame the fellows if it went bad. Otherwise, he said, well, they'll blame the fellows. So we did all these. We did 90 arteries, 54. We did them all with a microscope. Even John Gould was on this paper. We made John, who said you could do it with loops. We made him use a microscope. And 54% thrombosis, but there were some interesting things about it. The overall patency was 54. If we did just one artery, it was 47%. If we did two arteries, it was 58%. But if both were repaired or a critical injury where there wasn't good backflow, one or both were patent 95% of the time. So if you need it and you do it right, it'll stay open. So there's some issues going on, what really happens. Rothkopf did another study in the 90s, 28 lacerations. You see, it got a little bit better. We actually, at this point, we're learning the stuff that they told us in World War II in Korea that nobody bothered to read. Certainly I didn't read, that we needed to resect vessels, that we needed to not have tension, that we needed to do grafts, and the patency rate went up. But it will, and this was interesting, single vessels repaired without vein grafts was 100%. Well, what that said is that they weren't very severely damaged. Okay, so because we know that what matters is that you repair good vessel to good vessel, not under tension, and that there's not inappropriate backflow. So there are also other studies that show if you do vein grafts, it's higher. The key here is that you have to resect the damaged vessel. So what happens to the radial and ulnar artery in the forearm, and you have a non-critical injury? So just one of them is injured. Well, backflow does contribute to stasis. We know from all this data that resection of the damaged vessel and elimination of tension is crucial, that a precise technique, in this case, really is crucial because you got some sludging from that backflow to the point that we never could prove it. But after we repair it and let the tourniquet down, we'll actually occlude the other vessels so there can be flow and reestablish a good clot at the anastomosis. But I can't prove that. It's just something that we did. That the key is to breed mine and to eliminate this low-grade infection, which is one of the major problems. It only takes about 100 staph or strep on anastomosis to clot it, where it takes it takes a huge number of bacteria to cause a clinical infection. And you have to cover the anastomosis, and then should you anticoagulate them? And most people don't. So what are the demographics of this? Well, upper extremity here, they're not uncommon. At Baptist, they're not uncommon, but no, in the world, they're relatively uncommon. The variations in presentation are incredibly different, and they can result in significant morbidity and/or amputation. Very early in my career, I had a patient sent to me, and he had an attempt at a repair. It was 8 hours in another hospital. We took him back. We tried. The guy ended up losing his arm for a non-critical injury that didn't actually probably need anything. So it is something you need to be cognizant of, that you can do harm and you need to not do it. So should we repair them? Shouldn't we repair them? And the answer to that is you should if you can and it's safe. And we know that what happens is impacted by the mechanism, their premorbid status, the management that you do, the post-operative course, and everything that goes along the way. And there's a difference between civilian versus military. And I'll show you a little bit about what the literature says about that. So in civilian injuries, those are reported. Obviously, there are lots that aren't reported, and there are lots that are just occluded with pressure, and we don't even know about them. But if more than one artery is injured, most of these are penetrating for civilian. And I didn't put in the non-penetrating in this talk because that really confounds the issue. Distal pulses are present about a third of the time, so that's not a good criteria. Fasciotomy is less frequent than in the upper extremity or the need for it. And the functional outcomes are impacted very significantly by nerve injury, the muscle loss, whether or not they have a compartment syndrome, and obviously if they have an amputation. And out of these, 46 out of 100,000 in the civilian population that is reported, so these are the severe ones, end up with an amputation. Pediatrics different. They're less than 5%. Penetrating is more frequent than blunt trauma. Upper extremity more frequent than lower. The boys are more commonly injured than the girls. Mortality and amputation is significantly less than in adults. Morbidity is lower. And there's really significant data that shows that these are best handled in trauma centers, and that the morbidity correlates as you would expect with the comorbid injuries. If they're young, there can be an impact if you don't fix, these are major vessels, brachial, subclavian, on limb length. There's some conflicting data on that, but there are two classic papers that show in a significant major vessel will result in a smaller limb, not necessarily shorter, but smaller. And that if they grow, you need to use interrupted sutures so that the vessels can grow as well. So that's the one place that the vascular surgeons sometimes forget. We have to remind them that they shouldn't use running sutures. Now, the military is quite different, and it's changed a lot, especially with Afghanistan and Iraq. And the lower extremity is more common than the upper extremity, so that's different than civilian injuries. It has a much poorer prognosis, and again, the functional outcomes, same thing: nerve injury, muscle loss, compartment syndrome. And the total force is significantly greater. So here, if you look at Iraqi freedom, this is the study out of that Klaus did, and you can see that there's a fairly smaller percentage of the upper extremity. That's that red box in the lower corner. And you can see here the distribution of around the shoulder, the brachium, and then in the forearm, about a third each. That if you look at the demographics of it, again, you can see that this is the lower extremity versus the upper extremity, and there's significantly lower number of upper extremity injuries than lower extremity, but they can have significant morbidity. And then if you look at the overall salvage rate in the upper extremity, it's significantly higher. So there are fewer, but they also do better than the lower, and these include the subclavian and axillary injuries. There were in this group, though, 12 amputations in the upper extremity, mostly because of brachial plexus and nerve injuries. And a military mechanism significantly correlates with poorer outcomes. There's no question about it, just because of the total force. So the 5 factors that are most important in war injuries, very similar to civilian injuries, but brachial plexus now becomes a significantly greater problem in the war injuries. It's a problem, not skeletal injury. And so the amount of bone damage makes a huge difference. Compartment syndrome. And if you do a graft, and a lot of these had grafts, if the graft fails, that your ability to salvage it is significantly impacted negatively. So the treatment goal obviously is first patient survival and then quality limb outcomes. And I'm going to go through the key obviously is the collaterals. Where does the injury happen? Makes a huge difference. And it's important to remember that there are these, what we call superficial vessels. So a superficial vessel is where superficial brachial comes off above the shoulder. A superficial radial ulnar artery comes off in the brachium or higher. So that can confuse when you do the diagnosis. And then we know, of course, in the elbow, there are rich collaterals. And so that it may look pretty good with the brachial artery transected. But then if you do surgery or later one of the collaterals thromboses, that's when you get in trouble. And then the arches, we know the superficial arch is completed about 80% of the time, and the deep arch 97%. But again, where the injury occurs can make a huge difference. So at the shoulder, if it comes right across the brachial artery or the axillary artery and gets the collaterals at the same time, then you have significant morbidity. So if we look at the physiologic considerations, we've talked about comorbidities and the pre-existing patients in civilian population. Not many military have pre-existing neuropathy, vasculopathy. The coagulopathy is something that we don't pay much attention to. And we've noticed in our occlusive disease patients, but also in some of the patients that we repair, especially in women. We have patients with factor V Leiden or patients with protein S and C deficiencies. And so you find these patients and you don't understand why they're clotting off, but they actually have an underlying coagulopathy. So one of the key things to ask, which is one thing that you're all going to move to EPIC, but EPIC doesn't ask, if you're a surgeon, one of the most important things you should ask is there a history of stillbirths or spontaneous abortions in the family, because that's an indication that the patient may have factor V Leiden, and then you need Coumadin to protect them if they have a vascular injury. And then, of course, systemic disease. So military doesn't have that, but patients with collagen vascular disease are, again, at significantly greater risk. So the key here is what happens in a non-critical injury. Its definition is pretty simple, that there's tissue survival without vascular intervention. So here's a patient above that has a radial artery injury. You can see that the FDP and FDS are cut, the index finger's out, the FPL was damaged, the median nerve was cut. But this patient had good capillary refill and turgor and good vessels. But here's the critical, and without vascular reconstruction, you get tissue loss. It's quite simple. You can evaluate them at the bedside. There are lots of things you can do: color, refill, temperature. Temperature is sort of interesting. If the temperature is 30 degrees, if you look at the curve of temperature, it drops off precipitously below 30. So 30 degrees of temperature correlates with significant total blood flow. 29, it drops to half, and at 28 even further, which is why replants that are 30 degrees or above always survive. And if they drop down 29, 28, they often will fail. Allen test you can do pulse. Segmental blood pressure is probably the easiest thing to do, Doppler and ultrasound. So we look at color, refill, temperature, turgor, which is helpful to look at. And then you can assess the character of the pulse. Is it normal? Is it biphasic or stenotic, or is it occluded, sort of just thready? This is, you can use Dopplers. Here's a color Doppler that you can look at. And all of these things, but if you really want the best single thing to determine what the quality of the collateral flow is, at least at the time you're evaluating them. Now, if they have vasospasm, it may be artificially low. And that's one of the problems in evaluating patients. Once the spasm breaks, maybe their collateral circulation is good. But if they have good segmental pressures at the time you examine them, you know that the collateral circulation is pretty good. And so this is a nice thing. This is the digital brachial index, very similar to the ankle brachial index, that it's the digital blood pressure or the radial or ulnar blood pressure versus the brachial blood pressure. And just like in the lower extremity for diabetic feet or for vascular problems, if it's less than 0.7, that's bad. And if it's greater than 0.7, that's good. You'll have minimal symptoms. If it's less than 0.5, that's really bad. That means that cuts aren't going to heal and they're going to have significant problems. So greater than 0.7. So this is something you can do. Now, if it's low, that doesn't mean necessarily that they have no good collaterals, but it means they have significant vasospasm at the time you're evaluating them. And that's one of the problems with looking at backflow. So if you have backflow that dribbles out, you say, well, this is not good backflow, I'm going to fix it. But once the patient stabilizes, maybe that backflow goes way up. Now you get stasis at the anastomosis. It is by definition a hypercoagulable state in that area, and then you get a thrombosis. So that's been looked at multiple times in the literature. It's been studied in dogs, and we can't get an answer to that. But common sense would tell you that why would, if we have a total occlusion, we have a patient that we have better success rates with an amputation than we do with a single vessel. So it must be factors that are influencing what we do. But you can actually cannulate the blood vessels. We looked at that. If it's good pressure, you by definition have good collateral circulation. If it's low, you may or may not. So structural imaging, this is actually very simple to summarize this. You shouldn't do it. It's not recommended for penetrating trauma unless you suspect later that you have distal embolism or something that you missed, in which case you can do it. But a way that you can do that is you can do the same thing. You can put you have a tourniquet on, you can cannulate the vessel, you can inject a little renographin or Conray, and then you can take just a plain x-ray and you can get a very nice study. So you can save a lot of time by doing this. Why do we do arterial repairs? You need nutritional perfusion for survival, but you need pulsatile flow that responds to stress for quality of life, okay? So that you don't have weakness. So you don't need much blood flow to survive, but you need pulsatile flow that can respond to stress to do well, to play golf, to shoot ducks. And I feel guilty about killing that half a duck. I mean, what can you do? So remember that your hand is a thermoregulatory end organ that actually functions. And 80 to 90% of the flow in your hand sitting in this room is thermoregulatory. Only 10 to 20% is nutritional. So you don't need a lot of flow to keep it alive, but you need that flow to respond to stress. You need that flow in your forearm for your muscles. You need that flow in the rest of your body. This is an interesting study. This is another evaluation of arterial repairs, 166 single vessels. They did microscopic repairs. They brought back 30 of them. Group 1 were patent, group 7 were thrombosed, 76.6% patent. So again, people trying to prove that they could do something that physiology for something with it were just not smart enough to keep them all open. And they felt that their repair achieved better functional outcomes if they were patent by quick dash and less cold intolerance. Now in this study, we've done about 20 studies looking in arterial injuries and in occlusive disease. We cannot show that when you look at patients that you can get rid of cold sensitivity and cold intolerance. So if you have vascular injuries, it's hard to get rid of that. This study in Turkey, they were able to show that there was a little less cold sensitivity, but you can't really count on that. You fix vessels so you have pulsatile flow that can respond to stress, so that if they get an injury later on in the other vessel, that they're protected. And you do it only if you can do it safely and efficiently. So the factors influencing patency that are event related are the vessel that's injured, location, the level, and the mechanism. Again, we've talked about all these premorbid conditions, but the key is what's the natural history of if you don't operate on them, and you can't, and we've already talked about civilian versus military. So here we have an injury we were talking about before. So we have an injury across here, you get the brachial artery, but if it's at that level and it's a significant injury with a bony injury, you may impact significantly the collaterals, even though they're very rich collaterals. So a single little laceration, got plenty of collaterals, but you may have, with the same injury, good collateral flow or bad collateral flow. And your job is to look at that. So non-critical injuries above the brachial, what happens? You get hypertrophy and increased flow of the collaterals. They'll actually get bigger. Jesse Jupiter had a really interesting patient he had. So he was going to do a toe to hand transfer, and he goes in and, a policization, and he goes in and the index finger has a terrible little artery. So he ligated the branch to the long finger, and then came back 6 months later and the artery was 2.5 times as big. So that he showed that, but we do know from Gelberman's work in dogs and from some of the work that we did in the lab and some work that was done in the Netherlands, that there is hypertrophy and increased flow in the collaterals. but there persists to be a relative decrease in the segmental blood pressure in the watershed distribution of the damaged vessel. That there's a diminished resting blood pressure, just slightly, in that watershed area. Nerve recovery doesn't seem to be impacted. There's a lot of conflicting literature out there, but the total of it is that if you have an ulnar artery and an ulnar nerve, that it doesn't really make a lot of difference if there's good collateral flow from the radial. And that growth in older children is minimally impacted, but in infants, the arm is smaller and can be shorter. So there are some actually very interesting studies about that. If you look at that, that little red side is the summary of about 25 different articles. But those are the key things. That there's decreased flow in the watershed distribution, nerves aren't impacted. And if you fix them, and you can keep them open, it's better. No question. So battlefield, again, we're looking at, where is it injured, and then systemic versus civilian, and we've already talked about that. Now, what about the secondary factors? We know that prolonged ischemia is really important, and that there are significant intraoperative events that can occur that can be technical, that you do, and that the volume of devitalized tissue is really crucial. So the thrust of all of this is the debridement, okay? These next set of slides are the key is to debridement. Get rid of the dead tissue so that you don't have low-grade infection. Skeletal trauma and shock, all of this stuff fits into that. And that's really the major thing. Debride it, get rid of the damage, protect the patient goes into shock from other injuries, that's a problem, compartment syndromes. And throughout all of the literature, compartment syndromes, as they occur late from reperfusion injuries, are devastating. So it's really crucial, if there's any question at all, to do prophylactic fasciotomies. So the success rate in World War II, they said it was unlikely, regardless of the size. The last 6 months of the war, we realized that as the surgeons got better, as they did more debridement and their technique got better, that the amputation rate significantly decreased. And in the 21st century, we expect patency, but we don't always get it. It's important to understand that. Doesn't matter how good you are, sometimes you're just not going to get it. And that the key parts of this are local and systemic wound issues are really the key to this. It is not what we do. We can fix these vessels, but but you've got to resect the bad vessel. You've got to do it technically well, and then you got to deal with all the rest. It's the little piddly things that actually make a big difference. And the indications and the techniques are very crucial. So in non-critical repairs, micro technique, experienced surgeons, you're still not going to get 100% patency. And again, it's pulsatile flow. If it's reasonable, repair the vessel. Our goals are limb survival, satisfactory outcomes, and you need to decide what you're going to do. And we've already talked about that. The parallel vessel is going to increase in size. Triphasic flow is going to come back. You're going to have just like with the collaterals, you're going to get a minimal but sustained decrease in blood pressure. You're going to have some cold sensitivity. You're going to have some fatigability, and your nerves are going to recover. So the key is all these P's. I don't know, years ago, I decided I'd put P's in it. It just came out. You do all these P's: prepare, plan, precision, and then hopefully you get patency. So you need to resuscitate them. You need to get them there. It's really important. The key thing is the patient. You don't want to lose the arm, but you really don't want to lose the patient. And you need to give them fluid and blood products and planning, and you need to plan and then debridement. Now, this is one of the key things is especially in critical injuries where you need to decrease that warm ischemic time, and you need to protect them. I give them bicarbonate before I repair the vessel, so that if the blood flow goes back, you don't get all those metabolites, and you want to clear the distal bed. So with replants, we let arms, we let them bleed out. Now, we used to do a unit or two of blood. We used to do it until their blood pressure dropped a little bit, and then we put the tourniquet back up. But when we looked at the data from Iraq and Afghanistan, all you need is 200 cc's of blood, or about a unit, to clear it. You don't need to use as much as we thought you did in the past. You need to prep donor sites in case you need a graft. You need to plan your incisions. You want to use, especially for the brachial artery or above, but I like to use it for the radial ulnar artery. You want to use lower extremity veins. They won't dilate as much, and they'll survive. And we know that that the veins won't last as long as arteries. So if you have an expendable artery, that's better in a young patient. You can use the inferior epigastric or the thoracodorsal, and you can use parts from non-salvageable extremities. Prosthetic grafts are available. There's still some mixed data on those. This is sort of a classic, how the textbooks say to do it. Just makes it hard. Just make your incision perpendicular to the wound. I mean, when somebody cuts an arm off, we just make perpendicular incisions to it. Makes it easier. You don't get these big flaps that you have to worry about. So make it easy for yourself, because then it'll be easier for the patient. You need to stabilize them. This was interesting. We had huge arguments. Even though in World War II and Korea, they showed us that you needed to stabilize the bone first, in the 70s and 80s, our vascular surgeons and trauma surgeons were arguing, well, we need to fix the blood vessels first, especially in the lower extremity. And then we come in and fix the bone and, of course, damage the vessels. So we did this study. Hal was a general surgeon, Tim Pennell, general surgeon. So the hypothesis was that it was better to do the arterial repair first. Most of these were actually lower extremities. So they did the study, and we did it with them, and absolutely showed that it was horrible to do the vessel before you fix the bone. So it was, but again, if we had, I was too stupid to go, well, some of that literature didn't exist, but if I had gone back in the literature, we wouldn't have had to do this study, but we did it. You want to do rigid internal fixation. Remember to shorten, the key to nerve repairs is end to end under no tension if you can. So especially in the humerus, but we have unbelievably good results in forearm replants in nerve recovery that are better than isolated nerve repairs. Why? It's because we shorten the bone and we don't spend as much time. The most junior person fixes the nerve half the time, and the results are better than when the attending spends hours fixing the nerve, but we have to mobilize it. And if we shorten the bone, and with replants, we shorten the bone. So just remember that. And then external fixation just isn't as secure. So if you possibly can, you want to use internal fixation. Consider shortening. If you need to do a wrist fusion, what I do is take out the capitate, half the capitate, so I can get it really short, so I can get good nerve repairs. I don't worry about shortening it for vessel repairs. I shorten so that I can get end-to-end nerves not under tension. Debridement. Here's a patient that had this sort of crush injury. We shortened his humerus. What's hanging out there is the biceps and some of the brachialis. All of that is going to die. So we leave the tendon, but get rid of all of the muscle. And so I routinely, it's denervated. It's not going to work. It's just a bed for infection. I just get rid of all of that. And then wound exploration, stability here. So here's another patient. Shunt them, fix the bone, and then you can move on. And here's that other patient that we shunted them. This is a classic study out of Chambers, and Fox was one of the key people with this in the importance of shunting, showed the 200 cc's. Vascular prostheses are available. They use them mostly for transport, and then they redo them. Occasionally they'll work, and the short-term prosthetic grafts are good for stabilization, transfer, and then elective reconstruction. The key is to look at it. You need to have really good vessels. I found the key is if you can resect proximal to a patent collateral, then the vessel's pretty good. So here's just that when you look in there, you see the clot, and what you really want to see is that nice intima. So you look at it and resect beyond a patent branch, mobilize it, or then if it's too tight, then graft it. And here you can use an adjacent vein if you need to. Again, I still prefer lower extremity veins when possible. It's important to plan. So here's a big injury, and we took this graft and we routed it under some intact muscle. so that we don't have to worry about covering it. You can cover it with split thickness skin graft. You can put it right over the graft, or you can use a biologic dressing or a vac or a flap. But if you plan ahead of time and you route your graft, you can not worry so much about it. Here's Alexis Carrel showed this triangulation and the techniques back in 1912. Now we have resuscitation, we have antibiotics, we have anticoagulants, and still we're only a little bit better than they were then. Your repair can be interrupted or running, and then you can do end to end. So here you can see that, or you can do end to side. And then there are people that use couplers. I use couplers for veins selectively. I don't use them for arteries. Do you guys use them for arteries at all, couplers? Peter Apel in Roanoke was saying for acute injuries, he's been using couplers for arteries, but I don't like putting couplers in open wounds personally. Now, how do you deal with size discrepancy? If you look sort of starting from the left, you can take a V out and close it. You can, below that, you can take not more than 30 degrees. You can make a little bit of a cut to make it. You can make a slit and open it, or you can actually, if the flow is from the smaller vessel into the larger vessel, you can actually do this, what I call, it's a sleeve anastomosis, but I call it a little intussusception. And here you can sort of see that. And in this, you just put the suture into the adventitia and the edge of the media. On the smaller vessel, you put 2 or 3 sutures in, and then you put the other sutures through the vessel, and then you pull it in. This is very quick, has a very small learning curve, and is incredibly high patency rate. But it only works if you have a small vessel going into a large vessel. Need to do fasciotomies, really important to do that. I like to do them. If there's any question, especially if there's been prolonged ischemia, you want to do it prophylactically. Key to cover the anastomoses. We showed some ways to do that. Any question at all, you should leave the wound open. And then I like to do a second look. So intermittent, I take them back at 24 hours. Now, what causes thrombosis after repair? Most of the time it's technical, and it's inadequate resection of the damaged vessel. And I look at that. You have to be very critical of yourself. You tend to not cut too much so it won't be too tight, but you really do need to resect it so you've got really good flow. And then shock, metabolic insults, and exposed repair. But the most significant thing is infection. Here you can see it, but low-grade infection is really the most common cause. So arterial reconstruction is indicated for critical injuries, both the radial and ulnar artery. You ought to fix at least one, fix 2 if you can. The brachial, axillary, and subclavian, unless there is significant contraindication, reconstruction is appropriate. So here's a 19-year-old male, partial amputation, 2 centimeter skin bridge with a power saw. We reconstructed everything, and he did quite well. So that's sort of 150 years of penetrating arterial injuries in whatever, 45 minutes. Do you want me to do some questions, or I have a little overview of, it'll take about 5 minutes of the wake program.
Let's do that.
Okay, so let me just show you this. So we are Atrium, but the Wake Forest legacy is the north set. I don't know. I keep changing the name. We still have right. I think we're the northwest central region of Atrium. You're the greater Charlotte region. And then we have the Macon, Georgia region. So we got cities, we got states, and we got points on the compass. Somehow the taxonomy is a little bit confusing. Anyway, so what are we? So this is comp rehab. This is sort of our outpatient hub. This is the same size. This building is 140,000 square feet. It has therapy and all the subspecialties of orthopedics. In 1980, that's the year before I got to Wake Forest, there were 4 faculty and 15 residents. Now we have 57 surgeons, 4 op, 84 faculty. And we have 25 orthopedic residents, 8 fellows, 9 podiatry residents, and 2 physician scientists. We have 50 PAs and nurse practitioners. We have 32 athletic trainers, which combined with the Greater Charlotte, we have one of the largest athletic training programs in the world. Almost 100, we have over 80, 90 right now, changing daily. And we actually just added our own orthotics prosthetic practitioner. So we're increasing DME in that. We have 5 hospitals. This is what we look like now. And in the lower right is the new tower that's projected to start construction in about 6-9 months, which will help house our inpatient ORs, a new ER, although I'm not quite sure how we're going to get to it in the middle of all those parking decks, but and all of our ICUs. So the Northwest Central region has 5 hospitals. We have 3 ASCs, and then we have a major collaboration with the Salisbury VA Hospital. Our mission is clinical care, which is patient-centric, residency, fellowship, and postgraduate education, and clinically relevant translational research with excellence in all of these to provide value-added care. T talked a little bit about our physician scientist program, which started in '99, and we're very, I'd like to say that I had a lot to do with this, but really all I did was support it and pay for it. Others have really made this happen, but we're very proud of this. We have now trained more MD PhDs than any clinical department at Wake Forest, and a significant percentage now of the MD PhDs in all of orthopedics, we've trained like over 10, almost 20% of the MD PhDs in orthopedics right now we've trained, which just says there are not a lot of MD PhDs. That we have, the synergy is really exciting. This is a picture of the proposed new medical school that we have, especially combined with the Greater Charlotte, and we have significant clinical expertise in every orthopedic subspecialty, national and international recognition, tremendous opportunities in alignment with Ortho Carolina and Carolina Neurosurgery, and the huge athletic training programs. If you look at it, we'll have 3 residencies, 2 orthopedics and 1 podiatry, multiple fellowships, an MD PhD program. We have athletic trainer and advanced practice PA fellowships, and we'll have a medical school with 2 campuses, and when it comes to full fruition, 300 students per year between the 2 campuses. So incredibly exciting. So T and I have been charged by Gene Woods to create one of the top 5. I think he said 1, but I pushed back and said, how about 5? Top 5 musculoskeletal programs in the world. We're going to try for 1, but we're going to get to 5. So it's really pretty exciting that we're going to do that. As part of that, and T alluded to this, we're going to actually do some national and local and regional marketing. It's going to be targeted. It's going to be multimedia for both patients and reputation. Starting at this year, Cynthia Emery is going to be president of the NCOA. We're going to have an atrium booth there that will highlight both programs. At the Southern Orthopedic, we're going to have a booth and sponsorship, and Dr. Moorman will be the distinguished Southern orthopedist. And then he talked about this, an Atrium Orthopedics Journal, and I think we sent the deposit for this. So the residents that are out there, we need 2 residents to volunteer. There actually will be a small stipend, and it'll be a pretty good stipend, to be the guest editors for a journal that we're going to create within a year. This is Index Medicus, PubMed. So all those journals that people send you from your alma maters that they pay for, and write all these articles, they're not in PubMed. So we'll have that ability. And then since we'll own the whole journal, we'll put the sort of non-CME type things, peer reviewed. We can put articles about what we are and what we do, in this. So it's very exciting. It'll be a dedicated issue, resident editors, and then we'll highlight the programs. So I'm delighted to be here. I'm delighted to be a part of this, and had wonderful longtime friends in Charlotte, and now it's unbelievable to be able to be truly partners as well as friends. So thank you for having me.
Well, Dr. Koman, thanks for a fantastic presentation. I mean, what a whirlwind tour of over 100 degrees of history and vascular surgery. So that was fun to see. I know we got some great experts here that are going to have some questions for you. I want to ask a simple one first. When you're doing that digital brachial index, is there any consequence of putting that little tourniquet up on your vascular repair?
Well, no, hopefully your injury's up here. Yeah.
Okay, so that wasn't a replant. That was a
no.
proximal injury. Okay, good. So like you'd expect a sports medicine question, a dumb one. But
there are no dumb questions. They're only questions.
Gotcha. All right. Well, Glenn, Brian, vascular folks, hand folks, got any comments or questions for Dr. Koman?
Yeah, great talking. As always, two things that come out for me. One is you mentioned your preference, kind of losing your preference for vein grafts to go to lower for them. What about the role of arterial grafts instead? Descending branch lateral femoral cutaneous. I mean, lateral femoral circumflex artery seems to be gaining popularity. What's the role for?
I like that. Underneath that, I actually put arteries, expendable arteries, or especially in younger people. And there's not good data anywhere in vascular repair, in vascular repairs, but there is pretty good data in occlusive disease. And we're starting to see that if you use veins that, just like coronary bypass grafts, 7, 11, 15 years, they dilate and they thrombose. So I do offer electively in younger adults, we offer them arterial grafts. And if there is an available arterial graft and you're really worried in a young patient, I think that's a very reasonable thing to do.
The second one is you're on call, 2 o'clock in the morning, knife fight. The 22-year-old has an isolated radial artery laceration. I know you say that there's all the data. Now, do you think it's get up, go in the middle of the night and repair it? Hold pressure, bed them down, fix it the next day, or hold pressure, suture the skin, follow up?
I think you can do whatever, any of those things are okay. If you're there, the key thing is,
You're not there.
If
You're at home, you're at home asleep.
No, but if someone is there and they can do it appropriately, it's fine to do it. In a non-critical injury, this is the nice part. I mean, you can fix them at 6 months. And if they need it, if they have problems. So I think you can do any of those things, but you certainly can do it the next day. And there's no reason in the world, if we can do a tendon the next day, you can do an artery the next day.
What are y'all doing at Wake?
I think it depends who's on call.
Who's on call?
The fellows just like to do them that night, so they don't have to be by. But we don't have enough ORs. I mean, I've been there, almost 40 years. I mean, I've been through 5 cycles. We have enough ORs. We're now in that we don't have anywhere near enough ORs. So if we don't do it now, it's a nightmare to try. You can't do it tomorrow. You move it to an add-on tomorrow, you'll never get it done. So now you got 2 days later that you got to put it on where you can actually schedule it. So, but you send them home, take them to an ASC too. You can do that if you got a microscope.
Dr. Loeffler?
Yeah, it's a great talk. Thank you very much. Appreciate your expertise. So I was trained of the importance of shortening as well, bony shortening. And I'm curious, do you have any guidance as to when it's preferable to shorten to avoid a graft to allow you to do a primary repair versus performing some shortening, particularly for the nerve work, and then it's still okay to use a graft? So in other words, can we shorten a forearm, 5 centimeters, or do you say if the nerves are good and the bone is good, but we just need a 3 centimeter graft, or same thing at the humeral level or fingers? Do you have any guidance about a sort of general cutoffs that you would use to how much you would limit shortening to avoid a graft?
I have an opinion. I don't have any real data. I think an inch, two inches in the humerus, probably an inch and a half in the forearm unless the bone is really damaged or it's terrible. I mean, that's very tolerated. The muscle tension is reasonable. You start doing it much more than that. You can shorten the humerus more, but you start shortening the forearm much more than that. Everything's thrown off. I mean, your extrinsics are all too long. So probably, a couple of centimeters in the forearm, unless the nerves are no good. I mean, I'll shorten it more for the nerves, but I won't shorten it for the vessel. It's it's just another anastomosis with as good or better results. Where the nerve grafts, I mean, the nerve graft is never as good as an end-to-end repair under no tension. At least I can't do it any better. So, but I don't have any data for that. An inch, 2 centimeters in your humerus, other than shortening the sleeve of your shirt, nobody ever notices. And it doesn't seem to affect elbow motion at all if the muscles recover. I worry in the forearm though that you're gonna, if the intrinsic balance, the extrinsic balance is going to be, there's no way that I can adjust that. So that's sort of what I use, but I have no data for it.
Thanks.
I
Other
do have
questions or
unfortunately a lot of
comments?
experience with it, but no data. Although I don't take call anymore, so it's.
Can you pass the microphone back, Brian?
Dr. Koman, I'm Nick Lake. I'm one of the hand fellows. Kind of a similar question. I'm wondering, when you're setting up a repair, how do you judge if, tension, if there's too much tension and you're going to need to do a vein graft after you've mobilized and you resected some vessel? How much tension is too much?
If you look at people that say, well, if an 8-0 suture will hold it, okay, that's the classic response. I like it if it just will lay there. Okay. I think if you got to put an 8-0 suture and pull on it, it's too tight. So I like it to lay there. I don't like it to be redundant, but I just like it to lay there. You put a clamp on it, if you double clamp, but you don't want to pull it, I push it together and then I bring it back out and change it. But I really like it when it's done for the vessels just to be laying next to each other.
Other questions on the vascular talk? I've got some questions on the integration for you. Okay. Dr. Gant, I think we can see your image at least now, so fire away.
Thanks so much, Dr. Koman. That was excellent talk. Can you say a little bit more about your post-op protocol with regard to the anticoagulants? I know you said you'd take a second look, but what is your post-op protocol with regard to even sending them home?
Okay, so what I do is right before we let down the tourniquet or take the clamps off, I give them a couple of 1,000 units of heparin. And then we watch them for a little bit and then we'll close them. For large vessels in the forearm or arm, just send them home on aspirin. While they're in the hospital, I give them Dextran. There's no good data on that. And half the time now we can't even get Dextran. So I guess we've stopped doing that. But I do give my patients Thorazine, especially if they smoke, because it helps them. Interesting story about Thorazine. So, you know how Thorazine got to be used in the world? Okay, well, this is sort of funny. I had this kid at the Shriners Hospital in Greenville who was a quadrilateral amputee, and he had she had this vestigial foot that looked like a hand sticking off of her leg, and they're going to take that off because she couldn't wear a prosthesis. So I said, she had a below elbow amputation on those. I said, well, let's put that on her hand. So we took her to Durham and we transplanted. Paul Dell was the fellow. I was the chief resident, and Don Bright was the attending, and we transplanted this foot to the hand. Well, she was crazy. I mean, she's jumping around. She was 8 years old, and she got out of bed and she's flailing her arms. And so Don Bright comes to me, he said, but you did pediatrics. He said, sedate her. I mean, I didn't know how to sedate her. So I went down to the pharmacy, it was in the sub basement of Duke Hospital. Sat with the pharmacist and he said, well, he said, well, all these things are vasoconstrictive except Thorazine. So we gave her Thorazine. Well, then I'd found out, then I went back and looked at the literature. Well, Thorazine extends subdermal, random flap survival, and it has all these really good things. So then we got these automated typewriters. Okay, this was before computers. And so we did post-op orders on the typewriters. And I put Thorazine on the order sheet. So that's how we got Thorazine. Well, it turned out serendipitously that it actually is pretty good. And when you reviewed the replantation success rate in Louisville and Duke, which everybody argued about, that Louisville was better, Duke was better. That Urbanic always said, well, we should do 2 arteries and 3 veins. And Louisville said, well, we should do 1 artery and 2 or 3 veins. But when Andy Weiland reviewed the results, if you use Thorazine and did 2 arteries, the results were the same. That's how Thorazine got in there. But it does extend subdermal, it supports the subdermal plexus, extends flaps, decreases wound problems. So I use that. So what do I send them home? I send them home on Thorazine and aspirin while they're in the hospital. We give them Dextran. We give them, unless there's a lot of vessel damage and we're concerned about it, we don't anticoagulate the big vessels.
So you solve the behavior problems at the same time.
We did. And then actually, if it's real bad, I take a little of the Thorazine myself.
Gotcha. Well, in the interest of time, let me just ask you an integration question. A lot of our residents are here, and I know they're anxious to hear how this integration might affect education. And obviously, we know having the medical school and the innovation center are going to be fantastic. That's a few years off. Just time frame, in case I didn't mention before, we'll start having Wake Forest students rotating with us next year in 2022. The structure is supposedly going to be opened in 2024. That sounds pretty ambitious to me, but that's what the time frame is that the system is set. So we're excited about that. Now, as you all know, we have a lot of capability and a lot of availability here for rotations and whatnot. And we've got one of your chief residents that's going to be spending a little time with us this summer on a joints rotation, who wanted some specialty opportunity there. I would ask you, what opportunities do you see at Wake Forest that are unique, where you have capability and availability that might be beneficial to our residents? Anything come into mind where somebody might want to rotate at Wake?
I mean, I think that the beauty of doing this is that one, the trauma people have already started joint conferences, that we can have joint conferences. We've had for years, we have a meeting in hand and foot in the spring in the mountains. But really just, I'm not going to, we don't have anything that, what we do is a little bit different. It has slightly different emphasis, but, the programs are unbelievably good. But the opportunity is to just get a different perspective, because everybody does things a little bit differently. The trauma surgeons, do lots of things in common. The nuances of how they approach problems are slightly different. I think it's a huge opportunity to rotate just for perspective, to get to know how other people think and approach problems. And if you look at that, when we take these 2 unbelievable residencies, and then it doesn't double the power of them, it exponentially increases it.
For sure.
So I look at it is, if you want, there are 2 things as a resident that I would think of. One, if you're going to go into adult reconstruction, go someplace else and do sports medicine or hand or something that's different for a month or six weeks, so that you have that perspective. When I look back at my career, that it turned out the things that I thought I was never going to do were the things that actually I spent a huge amount of my career doing. So just don't focus too much. Yes, if you're going to do adult reconstruction or sports medicine or hand, that's fine. But before you do it, do the other stuff.
Mhm.
Don't just get, because that's what you need to know. And your friends are going to ask you, you're an adult, they're going to ask you about hand problems. They're going to ask you about foot problems. So if nothing else, do it so that you look smart.
Round yourself out. Good. All right, well, we've got some cases that we're going to present. So Glenn, is that your team? So we'll move to the second phase here if you all would like.
I'm going to get some.
Yeah, get some coffee in.